Well, welcome to the last WHA live stream. Look, Elisha and I are still sitting. We're still
here.
Vaguely compos mentis. The health ministers are leaving today, but the work is still yet to be done. The agenda is so behind schedule. Tedros says everyone has to be out by Saturday, but I think we'll take bets on whether that's going to happen. And of course, I am joined by my fantastic co-host, the CEO of the Global Health Council, Elisha Georgiou. Elisha, hi.
Hi, Ben. How are you?
I'm alive. Just.
And we are joined today by the wonderful Githinji Gitahi, the Group CEO of Amref Health Africa, who really probably needs little to no introduction to many of you. So thanks, Githinji, for joining us.
Thank you, Ben. Thanks, Elisha.
So as Ben said, we are woefully behind schedule at the WHA meeting, and universal health coverage, which was actually supposed to happen day one, is now scheduled to start sometime today, maybe this morning, maybe this afternoon. What are you hoping to hear from the negotiations on UHC?
I'll tell you what. I was involved in 2019 in the negotiations of the UHC declaration, and what came out is a conceptual paper. That was at the UN General Assembly. It's a conceptual paper that kind of captured everything, consensus. We didn't achieve much consensus on sexual reproductive health and rights. I think we had major challenges with the US government then on sexual reproductive health and rights. But even after we went ahead and put this paper, it was conceptual. I think the questions we're asking ourselves now, to your question, is what is actionable in all these declarations? So we, as civil society, but also the general community that is involved in the UHC movement, is as we negotiate now for the next high-level meeting declaration, which is in September, and as we align here at WHA, what is going to be actionable, what is going to be accountable.
And do you want to go ahead?
No, I was just going to say, so said in very diplomatic terms, what does that mean? And here's why I asked this question. Elisha and I have been having fascinating conversations about this podcast, this episode, and Elisha constantly corrects me around, is it universal health? Okay, it's coverage. But in my language, I've been using care. I've also been using access. And so the question is, what does this include? What really is meat on the table here?
Yeah.
If you're a carnivore.
If you're a carnivore, the meat on the table is financing. If you're a carnivore, the meat on the table is removing the fee for service. If you're a carnivore, it's removing out-of-pocket expenditure. That's what UHC is. It is to say, because primary healthcare, as we defined it many years ago, is just, access to health services for all, where they live, near where they work. It is what it is for all. So UHC came in because after the announcement and the agreement of primary healthcare in 1978, governments went back from Alma Ata and said, yes, health is an investment, it's a social investment. We must do this for our people. They hired community health workers or health extension workers, whatever they call them. They started to deliver resources. Then came the 80s, 90s, and debt had become a problem. And IMF, as they always do, and World Bank went back and said, with a little stake, hey, stop spending on social services, stop spending. We need to forgive you on debt, and we can't if you continue to spend on social services, because that's an expenditure. We want you to spend on infrastructure investments. We want you to build capital. We want you to bring private sector. So stop social investments. That was structural adjustment programs. What did the government do? They pulled back from social investments. They then said, there was a meeting that was held somewhere in West Africa. And they said, let's introduce a small fee for the medicines. Almost like you pay for the card or for the file or for the prescription. It is standard, but that will help the governments to actually recover some money for this treatment. That was part of the structural adjustment programs. Governments were told, if you don't show that you're actually recovering money, then we'll not forgive your debt. That was the beginning of the reign on primary healthcare. So when universal health coverage came, it wasn't to re-emphasize services and people need to get service. It was actually to re-emphasize that we need to remove the fee for service. That was the basis of universal health coverage. Get off. So therefore, when you say universal health coverage, you're saying how many people are covered against health costs. That is why it is coverage, not care, because care should be captured in the health. The health is care, it is prevention, it is promotion, it is all the services. The coverage reflects financial costs to the user.
Is that, I mean, and this is for both of you, is that helpful? I mean, does that make our advocacy stronger? Does it make it weaker? I mean, my question back to you both would be, coverage of what? Okay, this is making sure that whatever is in the list of healthcare services is affordable and available to folks. But that might be a paracetamol, it might be, holy water. I mean, it could be anything. So how do we use this to really force donors first, and then encourage the leaders of countries and civil societies in countries to make the investments in the health services that, at some point we should say everybody must have access to these.
And I just want to add the word quality, because I think that gets very lost in the financing conversation, right? That we do, and Githinji is of course totally correct that it's coverage, and you're really talking about costing. And I'm sounding like a broken record, but like, people are not their disease, people are not their financial circumstances, right? And so if you're talking about only access to services, we already know that service access is inequitable, but so is the quality of service provision. And so ideally, what you have are standards of quality across the board, so that no matter what health facility you enter, no matter what demographic you fall into, you're getting the same quality of services as well. And I think as civil society, we're often adding like, and quality, don't forget about quality, right? It's not just, like slap a vaccine in and send you on your way, or, like treat and street, as we say in the United States.
Get a shot in the arm.
and let me reflect on that, because actually this has been a huge debate in itself, the word quality. Because within what Ben is saying about what services, there's also what level of services.
Yes.
It's actually what we're reflecting. So there are multiple dimensions, what services and what level of services. Now, the conversation has been at multiple levels. Number one, on the services themselves, health is defined as a progressive human right. That is the problem. When you look at the Universal Declaration of Human Rights, there is a classification of the first generation human rights, that is civil and political. That is why if a country decides to stop Elisha from voting, it will be discussed at the UN. Like, this country is dictatorial. It's stopping people from participating in their civil rights. But if a country denies a woman access to care when she's pregnant, that is progressive. That's why no one complains, because the government say, we will provide these rights as we can afford them. So this is the issue, the quality issue, because there's no finite or black and white. So government say we are progressively providing. Of course, there's a big fiscal space challenge. If you look at, the US spends, and I'm just talking about public money, $5,000 per person per year on healthcare, public money. OECD, European countries spend $4,000 per person per year. On average, if you go to Africa and you do some back of the envelope calculations, $50 per person per year. That's not because they don't want to give 4,000. It is because the fiscal space, Africa has 3% of the world's GDP, but 17% of the world's population. So there's a big fiscal space challenge. Therefore, the question around what package of services and what is quality becomes embedded in that, because even the OECD, you have $4,000, you can do the best monitors. So is that monitor the measure of quality when you're in Chad, when you're in Malawi? So we are redefining quality to say that quality is where you get optimal results as desired, not the infrastructure you put in place. Governments will interpret quality, misinterpret it to mean excellence and size of infrastructure. So that has been a debate, back to that conversation.
Can we talk a little bit about that essential health package? Because I think that's the other kind of sticky piece that comes up quite a bit, that there's all of these global level analyses about here's what's in the essential package at the primary level, the secondary level, the tertiary level. So you have to somehow find the money in your domestic resource budget. We're not going to reduce your debt. We're not going to help you do that. Maybe you can start taxing people and set up a whole system to collect those taxes. But these things have to be in there. And there's always, and I know you talk about this quite a bit, the disparity between what happens at the global level and how health services are developed and deployed at the national level. And so what are your thoughts about all of this kind of trickle down? Like, you have to have this service, you have to have that. How do you get countries to put in the services that will have optimal results, and also navigate some of the issues that they would rather fund food for children as opposed to, reproductive health care? Where's the...
This is a very complicated issue because of what I talked about, the word progressive.
Mm-hmm.
So the challenge we have is that, and this is why it's important to actually look at the definition of universal health coverage a bit more clearly, which is what we're asking for, is that you can't offer all services for all people. It is not possible. Even the National Health Service in the UK is struggling.
Mm-hmm.
People are queuing.
That's putting it mildly.
Mildly. Thank you, Ben. And, so this is a big challenge. So the question then is, what's in, what's out? And that title is not mine. That is actually from a book written by Glassman,
Mm-hmm.
Amanda Glassman. What's in, what's out? So there is a process to say, depending on your affordability, what services do you put in your universal health coverage package based on your affordability, based on negotiation with communities and a consensus with community, because it's not just the government that decides, oh, this is what we are going to do. It's a consensus, kind of an assembly, consensus. So we know we want to provide from nutrition for children, vaccination. We want to also make sure that orthopedic services are provided, optical, dental. But for now, based on our health financing, we have done 15% Abuja. We have done taxing at the best level. This is where we should start.
Mm-hmm.
And then that package, depending on your finances, there are certain, of course, boundaries, and by health economics specialists will tell us how to do that. But the negotiation becomes very difficult because some people say, so why are you leaving my service outside? So some of us, and this is me now, have been thinking that actually the negotiation should be more around who, not the what. So you say, I am Group CEO of Amref South Africa. I have the resources to provide myself all the services I need for myself and my children and my family, including my mother. But there is somebody who doesn't have the money or the resources to provide themselves the basic services. So the government should say, this is the entire spectrum of services that are needed in this country, and we are going to progressively provide them. But we will make sure the last mile, the person who is most vulnerable, is the one covered by the government for everything, not me.
Mm-hmm.
So that we start to think about UHC, when we say 100%, when you say all, it shouldn't be the entire population. I actually think that if we were to put a lamppost for UHC, we should say it should be on the who, and we should start with the most vulnerable, the most left behind, the ones who are most disadvantaged, women, girls, people living with disabilities, people living in conflict. And we say 100% of those people will be provided 100% of the services. Then we start to progressively move. But this thing where government think that you can actually reduce your package from 100% to 25%, then you offer it to everybody. Then you offer nothing.
Right. Right.
Exactly.
But you have a political challenge there, don't you? Because who are the people who vote? Who are the people who have influence within governments outside of elections? And the temptation would be that you really want to ensure that they get the services that they need. And it's universally a challenge to provide care and treatment to the most marginalized. My gosh, even in the Bay Area, San Francisco, where I'm living, that is a huge challenge.
It is. And the issue is that in our continent, in Africa, the people who vote don't have money. Actually, the voting constituency are the ones without money. Because if you look at the middle class and above, they are minimal percentage-wise. So the people who are actually the bulk of voting, I mean, many countries have more than 50% of their people living under the poverty line. So those are the people you should focus on. And then the challenge that you're raising, Ben, is also now intersectionality. Because in a country like the US, the reason Black women have worse maternal outcomes than white women is not because there's no money. It is intersectionality. It is discrimination, racism. So that's a different problem that needs to be solved.
And I guess both of you are actually being, I mean, I completely agree with you, but you are both being quite brutally pragmatic. There is a pie. There's a certain amount of money. And the question is, and this is why coverage is so important, it's just how to make best use of that pie.
Yeah, I mean, I think it's also that, we talk about fiscal space for the health system. And I was in a conversation the other day about, paying health workers, community health workers. And one of the ministers in that said, well, we can't keep expanding the health budget. We're actually going to have to cut recruitment because right now it's taking 60% of our health budget. The health budget is part of a pie in itself. And then that is part of a bigger pie. I mean, the point about that I said earlier about reducing debt, right? You can't keep taking nothing, something from nothing. Like there's got to be a shift in the global fiscal space and a reprioritization where countries, when they commit and take action on universal health coverage, as we all hope, that part of that is saying, not only do we want you to put domestic resources in, but we are going to work with you so that you actually have domestic resources that you can put in there. And I think too, just at the national level, we all know the story of the Minister of Health budgeting without ever talking to the Minister of Finance. And then it gets to the Minister of Finance desk and he just slices the budget, never tells the Minister of Health it's sliced. And then halfway through the year, all the programs have to stop. So that also can't continue. But it is a pie, but I don't think it's the small little pie that we're talking about. There's really conversations that have to happen about what's the global fiscal space for this movement, and are we really committed to doing it?
Do you think we have the language to talk to the people who own the fiscal spaces? I mean, it's funny that you say that, Elisha, because fiscal space, I think, oh, that's basically going to the World Bank or IMF, or the treasuries or the departments of finance. But I guess, are we smart enough to make convincing arguments to our finance ministers?
Actually, now you bring another conversation here about a different constituency, and that's Parliament. Because ideally, the pass holder is actually Parliament. So we have done a lot of work, as Elisha is saying, to bring the Minister of Health and Minister of Finance together. And we bring them together. And above those two ministers is the president, who then, in some countries, can make decisions on budget. And therefore, the president then becomes the mediator in this place. So and this is why we keep saying health is a political choice. So if you manage to get through the head of government, then the head of government will then give instructions and say, my agenda is to do social investment for economic development. And I am going to do that in a long term. And therefore, I'm going to invest in health and education. And that's what I want your finance minister to do, invest in health and education. But if the head of government says, I'm going to invest in education and military, Now, if the Minister of Health goes to the Finance Minister, the Minister has already instructions from the head of government saying, I want my military to be invested in. So the negotiation then becomes narrow because, there have already been defined some key boundaries. So one of the things that we are realizing, even as we bring the Finance Minister and the Health Minister together, is in democratic states, a critical constituency is Parliament. And you need to convince the parliamentarians that their people are better off with health, their girls are better off with health, their women are better off with health. And what will that do? It'll increase their ability to realize their potential. It'll economically develop the country. And when they go to Parliament, in democratic countries, Parliament has thrown out the budget of the Finance Minister and say, we don't agree, go and redo it. So that's another constituency that we actually haven't involved a lot of. Now there has been discussions with the International Parliamentary Union, with the WHA movement. So there have actually been, but we need to take that now, Elisha, we need to take that to the country now, so that it's not only in Geneva, New York, but to go to the country and tell civil society, now we want you, and we give them resources, go and engage Parliament with the evidence that, and the language that Ben is asking for, so that they allocate money to health, because healthier populations allow healthy kids to learn and allow healthy adults to earn.
Yes, if you can deploy some of those folks to come talk to the U.S. Congress right now, that would be terrific.
Absolutely.
Yeah, they could do with hearing a bit of that.
They could. Yes.
Great.
So I guess neither of you have really answered the question.
It's because we're advocates.
Yeah.
So what question do you want us to answer, Ben? Ask it.
Very specifically.
Yes.
The care for, or the package of services for the marginalized. What is non-negotiable to you? What must be in there?
Well, there are many things that are non-negotiable, and many governments have actually picked on them. Child health is non-negotiable. Right. And this depends on country by country. In some countries, in the developed countries, infectious diseases are a thing of the past. But in the continent where I come from, the top killers are still diarrhea, pneumonia. Those are still the top killers. So child health, for many governments, any child under 5 accesses free services. So that's a non-negotiable, because that's the basis for even building your education system and everything else. Now, I think beyond that, the next thing is maternal health that we've seen government, because it's visible, it's palpable. A woman is pregnant, she has to deliver, she's in labor. You can't say, we will negotiate this. Yeah. So a lot of governments have found maternal health non-negotiable. Now, when you get into these other areas, then that is where the debate comes in. NCDs, for example, non-communicable diseases, nobody is bothered, both locally and internationally. Some governments, of course, that's a very broad statement. Many governments are, but generally, it is left to the individuals. The care for non-communicable diseases in some data says 80% of it is paid out of pocket. 80%. But for infectious diseases, child health, HIV, TB, malaria, because of course there is global consensus, which is driven by global health security. It's not driven by the needs of people. Right. It's driven by, if your disease can infect me, then I'll pay for it. Yeah. If your disease cannot infect me, then it's your problem. And that is the death of non-communicable diseases. So I would say that child health, maternal health, the rest of them have become debatable, and that is why advocacy is so important, to demonstrate, for example, that non-communicable diseases are going to be the next. Actually, somebody said yesterday, let's not wait for the next pandemic. The next pandemic is already here. And that's the pandemic of non-communicable diseases.
And those are expensive. I think that's the other piece, right? I mean, I think that even the access to diagnostics in a preventive setting is expensive and cost prohibitive for many countries. I know there's lots of work going on at this WHA about that, and a resolution on diagnostics is supposed to happen 3 days ago. Maybe will happen by Saturday. I don't know. But then once you are diagnosed, right, the treatment, because you can live quite a long time with a non-communicable disease, the full, whatever the full lifespan is, but the morbidity is quite heavy. And so for diabetics, insulin needs and the supply chain issues around that, it's quite expensive. I mean, we face that in the United States, that insulin costs are exorbitant for many people and they ration their insulin because they can't afford it. But cardiovascular, right? Then you're leaving primary care and moving into tertiary level for surgery, for interventions. And that is very pricey and few countries can afford that.
And there's something that you're both saying that's making me reflect, and for once I'm almost lost for words. But it is that if I go back to the late 80s, when I first started getting involved in global health, it was about HIV. It was the exceptionalism of HIV. And I found the global security arguments really compelling to force government leaders that they needed to invest in a comprehensive prevention and testing and treatment approach, so that it was young kids, it was mums, it was sex workers, but it was also soldiers and generals and civil servants. And I think we had some limited success, certainly into the 2000s, where we went from the millions to the billions of investment in HIV. But I wonder now whether we have, whether that is long-term not been helpful to us, because we are now at the point where we are siloing different health priorities. And you see it here this week. More people die of this disease than that disease. And I don't know that we're helping ourselves.
You can answer this. I feel like I answered this question with Ben a lot, so why don't you do it?
You're not getting out of it that easy.
I think he knows where I stand.
Yeah. I know where Elisha stands on this. So let me attempt to answer that question. When COVID came, ministries of health became ministries of COVID, because it was an emergency. So everybody's efforts went there. Of course, there was a huge cost because we fell back on vaccination of children. We fell back on NCDs, maternal health challenge. We fell back on all the other areas, but there was an emergency. So this was the emergency with HIV. Like, everyone was concerned that there was so much loss of life. So people focused on it. What should have happened, and what we are realizing now, what you're calling a mistake, is that once the emergency peak is dealt with, then we must ask ourselves, what conditions led us here? What led us to this point? And that's also the point we are not learning about COVID, that we should have asked ourselves, how did we get this huge fire in the room? We've now kind of put off the fire. The embers are still there. But can we go back and revisit the risk and the risk mitigation and what we didn't do that? Because if we did that, we would have then actually discovered that the reason we got that is the world is heavily inequitable. And we would have asked ourselves, how do we resolve the equity? The structural solutions, not more vertical funding. Secondly, health systems were weak, and therefore we should have built health systems. Third, there was no manufacturing in Africa. When HIV happened, we had a big problem, and that is why the equity issue rose, because the drugs were coming from elsewhere and they were being held and not brought to Africa. So once we resolved the issue, we should not have continued to supply the drugs from outside. We should have asked ourselves, how do we make sure this never happens again? I can tell you that I've looked at my own calculations, and therefore not very accurate and referenceable. But almost $60 billion have been spent by Global Fund and Gavi for the last 20 years. Now, how much of that has gone into solving the original problem? I would say close to zero. Africa still imports 99% of vaccines, but Gavi has been there since 2000. Why is it that Gavi did not say progressively, we are actually going to continue supplying vaccines because there's a problem, but at the same time, we are going to target a 20-year period where we must make sure 50% of those vaccines are coming from Africa? Because if you look at Gavi's, and you look at all the data, Gavi's business is Africa. 75% of African countries are Gavi eligible, 65% or more of Gavi investments are sent to Africa. So Gavi's business is Africa. So it should have been, how do we progressively shift the production so that we never have to have this problem again? Same with HIV.
Yeah.
How many of the HIV medications are being manufactured in Africa? Now we have COVID, and we are not learning the lessons. We are creating new structures instead of asking what brought us here.
Yeah, I feel that very strongly. And, during the 2000s and the 2010s, I delicately raised these questions, but I truly felt like a Cassandra speaking in the wild, mixing my metaphors terribly there. But I think it is really incumbent upon us now, after HIV, after COVID, we simply cannot let this happen again. And the idea that through Western largesse, we would send cargo ships with containers that have been turned into laboratories, and our northern scientist boffins would boffin away in these ships and make vaccines that could then be delivered into Mozambique or Namibia, and then the ships would go away again. That's just not acceptable, and there's no place for it in the kind of solidarity that us northern global health advocates and activists have to give. So yeah, I really feel that very strongly.
I agree.
I know you.
I also want to say, though, it can't be then the alternative of sort of companies parachuting in and setting up without co-design, my favorite term, co-designing and developing and ownership with the local community, whether that's subnational or national. But there are some bilateral donors who take that approach, which is also sort of making agreements and then coming in and bringing people in and building all of the stuff and then going. And we don't want that either, right? So there really does have to be a reform of the whole system. And it's hard to see that, frankly, happening when we can't even get through sort of, an agenda for a week with all the member states together. So the action piece becomes a struggle. It
becomes a struggle, and this is why we must learn the lessons and say, if we are going to form any structures like we're doing now, reviewing the HR, we are creating the pandemic fund, we're doing this, there must be a really strong agenda of sustainability, saying we are doing this pandemic fund, but it's not now an eternal structure that sustains people's jobs forever. That now it's going to be replenishment after replenishment after replenishment. It must actually say there is a key sustainability agenda. We are solving this, but this is a sustainability agenda. And by this time, we must drive ourselves out of a job because we'll have built the necessary systems for everybody to be safe from where they are.
You are preaching to the converted. I could listen to you for hours. Really, and I hope to. We'll definitely try to get you back on a Shot in the Arm podcast, but also I know my other partner in crime, Eric Gooseby, is keen to get you onto the Global Health Diplomats, as by the way. Oh yeah.
Okay, maybe we can just do all of these together. We kicked off the multi-stakeholder hearings on UHC as a tag team, so maybe we'll just keep going.
So I guess that's it for this episode and for our live streaming.
It's been fun.
Elisha, what did we learn?
We learned action is needed. Will it come? Question mark.
What we also learned, and you experienced this morning, is that UNAIDS, who very kindly offered us this room, don't keep supplies of water cups. So I have been on the hunt for cups
every day
on every single floor. And today, finally, I was successful.
Or it is just an incredibly thirsty staff.
Exactly.
So you should call Winnie.
Okay.
Well,
thank you so much, Githinji. It's
yes,
great.
Thank you.
Great. Thank you very much.
Well, that's it for this episode. Hope you have enjoyed all of our live streaming podcasts. We will collate them and they will go on all of our podcast platforms. Don't forget to subscribe and give us 5 stars. Go to our YouTube channel where you can see Elisha, me, and our range of fantastic guests day in, day out over the last 5 days. So if you're still at the World Health Assembly, wishing you the very best to get through the agenda. And for those of us working in the real world, let's get to it. Thank you. Bye-bye.